Hello everyone, this is Chadi Alraies from SCAI 2023 in Phoenix. I'm really privileged today to be with Dr. Messenger, who is a late breaker presenter as well as the chair of the scientific session in 2023. Dr. Messenger is going to talk to us about DCR contrast trial that was presented last night. Dr. Messenger, thanks for being with us.
Fantastic, Chadi. Thank you very much for having me. So we were able to present a late-breaking clinical trial last night in the first session of the SCAI featured science sessions for late-breaking clinical trials. The study that I talked about was the DCR for contrast, which is an evaluation of a dynamic coronary roadmap, which is a tool that is available on the Philips Medical Systems cath labs that basically allows us to create a roadmap to navigate in when we're doing coronary intervention.
Right. And this is something, an innovative technique, especially for people with kidney failure or any patients.
It really has its best options in patients with chronic kidney disease that are at risk. Prior to this study, there have been several small studies that have demonstrated reductions in radiation and contrast use with this, but there's never been a large-scale study in the real world. So we actually presented the results of a 356 patient prospective randomized trial that was performed in Belgium, Israel, Spain, and then at New York Presbyterian Columbia, and then at our institution at the University of Colorado. Nice. That we just completed and presented. The primary results were presented by Professor Escaned at EuroPCR that looked at radiation and contrast. We were able to demonstrate a 28% reduction in contrast use in patients who had angioplasty supported by the dynamic coronary roadmap compared to controls.
Quite significant.
Yeah. The data we presented yesterday was actually on how feasible was it and what was the quality of these images. Sure. So we were able, when in the trial, 98% of the cases that we generated a dynamic coronary roadmap, we were able to use those to guide the PCI, which was an incredibly high rate for a new technology. And when those were rated by the sites, they were rated as good or very good roadmaps by quality and then the degree that the overlay correlated to the coronary anatomy in 79% of patients.
Interesting.
And then again, that correlated, the better the coronary roadmap, the further reduction in contrast. Nice. Importantly, in patients undergoing multi-vessel PCI, when you were able to generate multiple maps and multiple projections, the quality went up to 90%. Suggesting that we would even get a further contrast dose reduction as we do more complex PCI using the roadmaps. And so I think it demonstrated the feasibility of doing it in the real world. We had multiple sub-investigators, so 4 of my partners enrolled, so it's a very easy to use, simple to integrate tool for doing coronary intervention.
That was my next question is, I know you are, as a PI, you are trained in the software, you know what it is, but it sounds like this is easy, replicable for any operator in the cath lab to use it to map the plan for the intervention.
It really is plug and play. It takes about 3 to 5 seconds for the roadmap to be generated once you do a coronary angiogram. And then it's useful if you change gantry position and then come back to it, the map is available as long as you don't move the catheter or the guide catheter, which is what it uses as the landmark to orient the map.
And so it requires one contrast angiogram for each system, right and left, and that's what it is to plan for the procedure.
Yeah, you can take any view. When we broke it down and looked at staged PCI versus ad hoc PCI, if you're doing a staged PCI and you know what your projections are out of the gate, it's an incredible tool because you take one picture at the beginning of the case and you might not need to take another picture or just do a completion angiogram.
I'm going to ask you a question, I'm not sure if it is covered in the trial. How much the IVUS used or imaging used in the trial?
In that trial, there was about 35% of the patients had intravascular ultrasound imaging. There was, I think, very low rate of OCT, if any, but the rate was reasonable. Obviously, it was distributed among sites. Our site, we're close to 100% intravascular ultrasound imaging, and some of the other sites weren't.
Because I feel like if you have a roadmap and then you complement it with IVUS, you have all the information you need to plan your intervention.
Certainly, if you're thinking about ultra low dose contrast interventions, I think IVUS fused with the roadmap would really, or OCT would really be complementary technologies for minimizing contrast and and we do that.
Well, this is really amazing, the trial, especially now we treat patients more comorbid and more creatinine, CKD patient, and as well as patients who are close in the stage.
Yeah. Yeah,
So
it certainly has the potential to allow us to do much more complex coronary intervention safer in patients with kidney disease and at risk of kidney injury from contrast.
Well, thank you so much for your time, and
Thanks.
congratulations for a wonderful results.
Thank you.
Please watch these videos and others on the SCAI-TV. This is Chadi Alraies from Phoenix. Thank you so much for your time.
Thank you. Thanks, Chadi.